You know what I'm talking about.
All right. So, week 8 topics. So, for week 8, I'm just pulling up the module. So we have home care, community resources, case management, and then care of chronic complex illnesses in the community. So that is kind of what we're going to talk about today. Now, one question is, did anybody watch the recording that was posted in Canvas? No. All right. All right. So we will start with We'll start with, we'll just start with home care. So, what's home care?
Home care is for like anybody that's funded by the state or their insurance to get proper care at their house, like a private nurse or a private CNA.
Okay. So, how do you think that differs from providing care in a facility or in a hospital?
The needs, the cos not gonna say cosmetics, oh my God, I got a brain fart. One-on-one care and the supplies. Yes, the supplies.
The care is more
Okay.
personalized.
It's more personalized, right? We're in their environment, right? So we're in their home, we're in their environment. Um, and so traditional home care is illness related care for those patients and their families or those clients and their families in their home setting for homebound patients. And so when we look at not just that, but it could be even public health nurses and population nurses that go in to do primary and secondary prevention measures. And so a lot of training, a lot of education is provided to the patients as well as the families. And then, of course, the nursing care as well for both the patients and the client or the clients and their families, whether it's a transitional period or even a new diagnosis. Um, we even have home-based primary care, which I think is a really interesting topic as well. It's telehealth. And so, people that can't travel or, it's long distances between, like, and think of some of your rural areas where we can use that telehealth. Has anybody ever used telehealth? Has anybody done like any like telehealth visits, whether it was like COVID, right? COVID kind of made a lot of that really popular, right? Um, and now, not that it wasn't available prior to COVID, but COVID kind of really made it, even more, I guess, I don't want to say popular. That's not really the right word to use, but it's, we kind of understand a little bit more about like the availability of it, right? And how much can really be done, get on some of those teleconferencing systems, kind of like Zoom. There's other ones that they use, right? And they're, can be pretty effective. Home care is often too, one of the big things is often intermittent, right? It's a lot of times, it's not always have a nurse available for you every single day, 8 hours a day. It's intermittent. It's usually not long term, of course, depending on the situation, but one of those main goals of that home health nurse is to provide the education for um, the clients so that they can perform their own self-care, whether it's teaching them about how to do their treatments, use equipment, their medications, that kind of thing. And it does allow, the clients to get a little bit more self, some control. It helps to prevent hopelessness, loss of self-esteem. Because I mean, if I don't know about you guys, but like, let's think about a situation. If you had to have a knee replacement, a hip replacement, or something along those lines, where would you rather be recovering? Would you rather recover at home or would you rather go to a skilled nursing facility? Anybody?
Facility to get a break.
Okay. All right. You want to
I'd
go
rather
to a
be at home.
facility? I'm sorry.
I'd rather be at home.
I'm right. Yeah. So I cannot actually can see both sides of that, Dara. I could see both sides of that. Um, get somebody else to kind of not wait on you hand and foot, but you kind of get a break from life for a little while, right? No kids, no responsibility. You're kind of just rehabbing. Um, but yes, but a lot of people would rather be at home in the comfort of their home, and recover, surrounded by friends, by just familiar environment. Um, and so, we can get them to do that at home. Um, when tell me about going into somebody's home, though. What do you think that's like?
You have to be like culturally competent and just aware of your surroundings, and you have to get to know the patient more than you would if you were at work, and then like get to know the family too, because they're going to be very like hyper vigilant of somebody being in their home taking care of their loved one.
Very good. Be very aware of your surroundings. Yes, we're going to provide cultural care. It takes a lot longer for a home health nurse to do their assessment than it would if they were in a hospital or if they were in a facility, right? Because we're guests in their homes, right? We're in their homes, we're guests. And so we, have to gain their trust. We have to establish that partnership with the client as well as the family, right? Because like Sarah said, they're going to be hyper vigilant. Somebody else is in their home. Um, and so when we look at documentation for home health, there is a system, it's called the Omaha system. The Omaha system is the charting system that home health nurses use to organize, to sort, to document all that pertinent client data that they are receiving. So think of when you go and you do that head to toe assessment on a patient, and you have to go back into into the chart and you have to document that. And that's kind of the same kind of system, okay? It was actually developed by nurses, by visiting nurses, and it's based on those home care documentation needs. And so it is only used by home health nursing. But they are able to identify everything that they need within that documentation system. And nurses aren't the only people that go into people's homes. What other services can we provide for home care?
I mean, like therapy or occupational therapy, stuff like that.
Yeah, so we can do occupational therapy, we can do physical therapy, we can do speech
Respiratory
therapy.
therapy.
Hmm?
Respiratory therapy.
Respiratory therapy, right? So years ago, right? If people had complex needs, even kids that had complex needs, right? A lot of that time they had to be in the hospital especially if they had, tube feedings and IVs and ventilators and trachs, and I'm trying to think of what else. Foley catheters, right? We took care of them in the hospital, right? Now people are being sent home with medical devices, and we are training them on how to manage the equipment, manage the chronic disease, right? So that they can be comfortable within their own home. And so, yeah, we can definitely do physical therapy, occupational therapy. your speech therapy, your respiratory therapy within the home, right? Especially occupational therapy. Think about that, right? That's moving around. It's how to do your laundry. It's how to cook, right? What kind of what kind of adjustments can we do based off of their diagnosis and their physical limitations, right? And so we're teaching them how to do those things in their own home. Um, and so other things, just like, with the Nurse Practice Act, there are regulations that dictate home health as well. Medicare regulations, there's, the state licensing boards, all of that. Plan of care, they're going to have a care plan just like they would in a hospital or in a long-term care facility. Um, the RN is going to write the nursing diagnoses. Um, you're going to collaborate and do the planning and the interventions and, of course, the evaluation, except this is just going to be in that patient's home. And so one of the big things that home health nurses that need to have really good communication, right? So the CNA, the LPN, the RN, they may all be assigned to the client, but then not all going to be there at the same time, right? So the RN is going to do the initial assessment, right? The LPNs may go in to do whatever care, and then CNAs may go in and do personal care, but there needs to be that open line of communication being between all three. So in order to qualify for home health, they have to have a skilled need. All right. So that a skilled need needs to be there when they are getting discharged. It's not just generally for, being weak or, having pneumonia. They have to have like a skilled need, like IV antibiotics, wound care, trying to think of what else would qualify as a skill need, post-stroke, that kind of thing, in order to qualify for them to have that skill need. Going into a patient's room, or a patient's home, right? We talked about building trust. We talked about being, hyper vigilant about our surroundings. What are some things in the home that we are looking at in regards to our clients?
Iris.
Fall risks, absolutely. Right. So what are some things that increase the risk for falls?
Like rugs, dim lighting.
Poor lighting, your throw rugs. Um, what else might we find in clients' homes? Remember, not everybody lives the same, correct? Right? So, what are some other potential issues that you may run into in clients' homes?
Stuff that's like cluttered on the steps.
Clutter.
Stairs,
Say that,
stairs,
Michelle.
stairs.
Stairs.
If
Anybody
they
have
don't
pet?
have if they don't have banisters, they might need something to hold on to. Well, that wouldn't be a risk, but that would be something to
Well, it could
prevent
be
it.
a risk, right? What if they had
Right.
surgery and they have to go up and down the stairs, or they need something to hold on to, right? Pets could potentially be a fall risk as well. Anybody have pets?
Yes, and my cat is always running in between my legs.
I have two big German Shepherds and they are always in my way. No matter what I try to do, they're always in my way, right? So they're a potential risk as well. Um, But, then, hoarders and clutter, that is a real situation that you may run into. People's levels of cleanliness are not the same as well, right? So how we keep our homes, it may not be the same when we go into others, right? So it's non-judgmental. We're not there to judge them. We're there to provide them with their nursing care. Um, so just, kind of think of, anybody want to do home health or has anybody ever done home health? Yeah. Did you enjoy it? Yeah. It could be. I mean, I know some people that really enjoy doing home health. You meet a variety of different people across all lifespans. Um, I personally don't I don't want to go into strangers' houses. That's just not my comfort level. Um, Night lights would be another potential prevention for falls. And I'm not telling you to go in and tell your clients to get rid of their animals, right? But we need to see just so that they can be a little bit careful with them around. Um, Community resources. So, who has started their vulnerable populations project? All right. So, what are community resources?
Each community is different, but some might be like food banks or
Like Meals on Wheels,
yeah.
programs like that, mom meals for moms,
Okay.
um,
Oh, I hadn't
people
heard
that
that
go
one. Okay.
people that go out into the community and give out like you know how they have like those health vans or like the buses and they give free medical attention to those
Oh,
people,
yeah. Yeah.
things like that.
Okay. Yeah. So community resources are just used to enhance self-care capacity. They can be used to manage complex chronic illnesses, also help to reduce vulnerability in our vulnerable populations, right? So, think about like, you know, mobile clinics, free clinics. It's your health department, your Meals on Wheels, your Red Cross, your clothing banks, your food banks. It could even be some of your churches, your domestic abuse shelters. Trying to think what else. Other types of volunteer services that are potentially um, available to help. It could be transportation services, even sitter services in some cases. So just like an example, so one of the churches, not one of the churches, there's before I moved to Texas, so I'm just going to go with Virginia because I still don't know a whole lot about the area down here, but so a bunch of the churches would get together, especially during the winter time, and they would do something called a night's welcome. And so a night's welcome was for the homeless population. Um, and so they would advertise it. And so the churches kind of took turns. I want to say they did a week at a time. And so what they would do is there would be buses that would provide the transportation. So they would bring them to the church in the evenings. They would get a meal. They would get a nice, safe, warm place to stay for the night. And then the next morning, the bus would take them, I want to say to like I think it was the YMCA, and there was another place where they could shower. And then there was where the Y was, it was actually attached to the health department. So if they needed any medical services, they could get them while they were there. So there's different, depending on where you're at, depending what city you're at, right? How big your city is, right? How much they invest in the community is going to determine the resources that are provided. And this can also even be, things like WIC and TANF, right? That are available depending on in most communities. Domestic abuse shelters, those aren't advertised. They are available in most places, right? But you're not going to find, the address in online or in the phone book. Right? They're protected addresses. Um, when we're looking at other community resources and we're working with your non-English speaking community, working with the non-speaking immigrant community can be a little bit more difficult, especially if the leader or people don't speak their language, right? So how do you think we could build trust in non-English speaking communities as far as like public health nursing would go? What is a good way for us to build trust with those people?
Put in the effort and try to get a translator.
Okay, put in the effort, get a translator.
Or
Looking
make
up,
sure it's diverse and they already have somebody that's there that looks like them and speaks their language. I mean, it might
right.
be easier said than done, but that would make them feel more comfortable.
Well, then, I mean, we can look at that. What about going with their community leaders, right? They may have community leaders that are there to help them, to assist them. And so we can help by, getting to know their community leaders, building a relationship there, and then developing a plan to reach out to that, the immigrant community, right? So if we can build the trust and we get to know the leaders, we can establish a plan. And that is where we can get the translators, and we can also get, some of their maybe others to help translate, and get those messages out to them. We can also advertise in, if they have like their own newspaper, even commercials that are in that language, right, to kind of reach out to that population, in order to help them get the resources that they need. Who's heard of case management? So, has anybody ever worked with a case manager or seen a case manager? So, case management is a way that it helps to kind of coordinate care for individuals. And case managers are usually reserved for high cost chronic diseases like your asthma, your diabetes, your COPD patients, your cirrhosis patients. They are it is very labor intensive. It's very time consuming. It is very costly. Hospitals have case managers. Some of your public health departments have some case managers. Insurance companies also may have some case managers depending on the situation. Um, but it's usually with your case managers, they usually have a very high caseload. Um, and they often are overworked, excuse me, because there's a lot. Um, it's it's unrealistic to say that every client is going to have a case manager, just because it is very labor intensive, it is very costly, and there are still probably people out there that need to have case managers that don't. But case managers are advocates, they're care coordinators, they're referral agents. Um, and so think of, let's say you have I don't want to use COPD. I'm gonna use diabetes. All right, so we'll use diabetes as an example. So a diabetic will have a primary care provider, they'll have an endocrinologist, they may have a nephrologist, they may have a neurologist, they may have a cardiologist. So that's five specialists or five different providers. And so, what that case manager can do is help to coordinate the care amongst all of those providers. And so, one of the biggest challenges with case management is what we call fragmenting of services. And that can result in overuse or underuse. It could lead to gaps in care. It can lead to miscommunication. Um, and so that case manager kind of tries to build that gap, so that we can, streamline services so that, the cardiologist and the endocrinologist and the nephrologist, they're not all three, ordering the same medication, or they're all three ordering the same test, right? So we can kind of make sure that we are not overusing or underutilizing the system. Um, and I don't know about, how many of you use your primary care providers, but like your primary care provider, they're typically the one for like people that don't have a case manager. They're the ones that primarily like coordinate our care, right? So if something happens, and let's say you slipped and you twisted your ankle, right? Most patients, right, you start off at a primary care provider, and then maybe the primary care provider will send you to orthopedics, right? They're the ones that kind of coordinate those referrals for us. Um, and in a way, that's kind of the same thing that that case manager is doing. They're just kind of core helping them with appointments, sometimes with transportation, helping them to understand what their treatments are. But, they have to know too, and, what's going on with those patients. They need to know what available resources are within the community, how they're financed as well. They need really good written and oral communication skills, negotiation, conflict resolution skills. They also need to have really good critical thinking processes, as well as, taking that all into consideration to provide the best resources for the best desired outcomes. Um, so like I did spend some time with a care manager during, I think it was my bachelor's program. And so she would, call them to remind them of their appointments. And sometimes she would even set up transportation to make sure that, they had transportation to get to their appointments. Making sure that, they call their refills into the pharmacy, that they picked up their refills, that they went to to their appointments, that they understood what their treatment plans were with each of their appointments. So it is very, and if you've got 20, 30, 40 patients on your caseload, right? That's a lot of people to try to keep track of. So the documentation, right? The communication, time management, all of that is absolutely necessary when we're looking at work in case manager. And then adapting that case management care plan to each one of those patients, just like you would adapt your nursing care plan to your clients, right? They're going to adapt that case management plan. And it's just linking all those different providers together. Um, and, I don't know if anybody is like, there's different types of roles out there now between with case management. I forget, I think they're called health coaches. So, LPNs, RNs can all work as health coaches. And it's kind of the same kind of thing. It's kind of linking your providers, making sure that, they're checking their blood sugar, they're checking their glucose levels, that they're scheduling their appointments. And if they have any questions or, any kind of concerns, then that nurse just provides some health coaching, either, nutrition, diet, exercise, um, other things to look out for regarding, their specific disease processes. So there's lots of opportunities out there. But it can be a very stressful situation. So, but the biggest part of this week is care of your complex illnesses. So we've got a bunch of different ones. So we'll start with post-op care. So what are, let's see, LaShawn, what are some concerns that we may have post-operatively? LaShawn, are you there? All right, Destiny, what are some concerns we would have post-operatively?
Bleeding.
Okay, bleeding, absolutely. What else?
Clots.
Blood clots. Okay, good ones.
Infection,
Um,
pain.
Infection, pain, absolutely. Um,
what's the hospital acquired pneumonia if they're not moving around? I mean, if they don't.
okay, hospital acquired pneumonia, very good. Yep, all of the above are absolutely correct. It's always ABCs, right? Airway, breathing, circulation, pain. Pain is a big one. Um, So we think of airway, you said pneumonia. Atelectasis is also a possibility, especially if they've had general anesthesia where they've been intubated. Your pulmonary emboli, right, from a blood clot. It also could be respiratory depression, right? So think of, we're giving them medications. Um, there are, the opioid medications for pain control. We know one of the biggest side effects from that is going to be your respiratory depression, right? So we need to watch out for that. Circulation, that's your DVT. It could be sepsis. It also could be dehydration just because of, think about it. You're going in for surgery. You're going to be MPO, right? Anywhere from 8 to 10 to 12 hours prior to your surgery. So dehydration could be a potential issue. Um, Urinary tract infections, if they have had a urinary catheter. And then, like somebody said, infection, wound healing, pressure ulcers are also potential. Think about patients that have had extended surgeries. They've been in, one position for a long time, or even after surgery, if they are bedbound for any period of time, they're going to be at risk for pressure areas. Talked about pain. Um, Nausea could be another potential. Post-op nausea and vomiting is common for some that have had anesthesia. Constipation is another one that could be related to the pain medications, or it can be related to immobility after surgery. So, with all of those wonderful complications that are potential, what are some ways that we can prevent those from occurring?
I know the
So,
for
yeah,
oh, go
yeah.
ahead.
No, go ahead.
For the legs, I know they put those things on the legs to for the circulation. Then you can use the how do you pronounce it in something spirometer.
Incentive spirometer.
Yeah, the incentive spirometer. You can use
The
that.
deep breathing and coughing.
Yep.
Mhm.
So
You
turn
do
cough
that
Am
and
every
deep
two
breathe. Yep.
hours.
ambulation.
Ambulation. Absolutely awesome. So yes, turn cough and deep breathe. Incentive spirometer. Um, what else did you say? I forgot that quick. Oh, the SCDs, we call them sequential compression devices. I'm trying to think of what else they've been called. But they're the ones you put on their calves, right? And they squeeze and they let go, and they squeeze and let go, just to help to encourage blood flow. Um, what about preventing wound infections? What are some ways that we could prevent wound infections?
Proper caring, like
Turn
when
every
they need to get changed, change them.
turn. Make
Hmm.
sure you're turning them every 2 hours.
Yep, turn and reposition every two
Proper
hours.
hand skin assessments.
Skin assessments, absolutely. Using sterile technique, right, when we're changing the dressings. Um, what are some ways to prevent nausea or help with nausea? Maybe not prevent it.
Small meals.
You keep like if they do vomit, get rid of the vomit bin right away and keep it the room odor free as possible.
There you go. Yep. What did you say, Dominic? I'm sorry.
I said small frequent meals.
Small, frequent meals, right? One of the goals is to keep them hydrated, right? So small sips of fluid. Um, in addition to the turning, and getting them up and moving and the sequential compression devices, what's another common method for the prevention of blood clots?
Getting up, right? Like getting up and walking.
Yeah, getting up and walking. What else? Rakaya, what's a good way to prevent blood clots?
Using like um anti stockings or something.
Compression socks.
Yeah,
Compression socks, okay. What medications do we use?
anticoagulant.
Hmm? Anybody? What medications do we use to prevent blood clots?
Heparin.
Heparin. Yep. So we can use heparin or we can use enoxaparin, which is Lovenox. Right. And there's some other ones now. Once they're leaving the hospital, we can switch them, either keep them on Lovenox or we can move them to one of the oral medications. Some of the newer medications don't require the frequent blood testing like warfarin does, right, for the PTINR, or even for heparin with the APTT. Enoxaparin, which is Lovenox, doesn't require frequent testing. So it's a little bit more convenient. How do we prevent constipation?
Fluid.
Lots of fluids, right?
Fiber.
Fluid.
Fiber. You can give them like Miralax.
Yeah. So fluids, move,
Store, store,
Miralax,
store softeners.
stool softeners. Very good. Yep. And then, and that's one of the best ways that we can prevent those post-op complications, right? Is to get them up and moving. Um, what has anybody heard of cirrhosis? So with cirrhosis, there's a variety of causes for cirrhosis. Alcoholism can cause cirrhosis, your hepatitis B, your hepatitis C. We also have what's called non-alcoholic fatty liver disease, which is not related to alcoholism as well. That's why it's called non-alcoholic. But those liver cells are destroyed, and they are replaced with fibrotic tissue. And fibrotic tissue can't function like normal liver tissue. So it can disrupt blood flow through the portal circulation, which leads to blood backing up into it, um, which is what we call portal hypertension. And with portal hypertension, the fluid eventually will leak out because it doesn't have anywhere to go. It's kind of stuck in that portal system. So the fluid leaks out of the capillaries into the abdominal cavity, and that's what causes ascites. Um, They'll also develop what are called varices. And so they can develop varices within the abdominal cavity. They can develop varices within the esophagus. Um, and the reason why the fluid is leaking out is because liver that's not functioning very well anymore, can't produce enough albumin. And if you remember what albumin does, albumin helps to keep the blood in the veins or in the vascular system. And so if the albumin's not there to maintain that oncotic pressure, then the fluid is going to leak out into the interstitial fluid or into the interstitial tissue, and that's what leads to the ascites. It can also cause something called anasarca, and anasarca is just a big fancy word for generalized edema. So it's edema everywhere, not just like in the lower legs, but the arms, the legs, and they're swollen everywhere. Patients with cirrhosis generally will have fatigue, they'll be weak, headaches, abdominal pain, they'll have nausea and vomiting. They are also a high risk for bleeding and bruising because of a vitamin K deficiency. They'll also, because of the decrease in the clotting factors, because if you remember everything that the liver does, it does help to synthesize vitamin K as well as those clotting factors. Um, and then with the buildup of toxins in the system, they also may develop itching or pruritus. And that's as the toxins are building up in the blood, they start to leak out and leads to itchy skin, kind of like the same way that dialysis patients have the same issue. They have that itchy skin. They'll also develop jaundice, which is that yellowing of the skin. Usually we'll see it in the sclera first. Their sclera will appear yellow, and then eventually they'll continue to be yellow. Has anybody ever seen jaundice? No. They are yellow. When I say they're yellow, they are yellow. You will definitely know jaundice. Um, they'll have pale colored stools, dark urine, and that is it's a result of bile not leaving the liver and it's being dumped in the intestines. So it's being excreted with the stool. Um, so some of the interventions that we would do for patients that have cirrhosis, they have all that extra fluid, right? Then we're going to put them on a sodium and fluid restriction. We could also use diuretics. That diuretics, right, will help to pull some of that fluid out of them. They'll be on fall precautions. With the buildup of the toxins, it can also lead to confusion and just the general disease process can lead to weakness. So that puts them at a risk for fall. Um, be really careful with over-the-counter medications, anything that could potentially damage the liver even more. Tylenol comes to mind, right? We know acetaminophen is very damaging to the liver. Um, we also want to be careful with um, we want to do daily weights. We want to measure their abdominal growth daily. That's just telling us how swollen they are. That's the measurement of the ascites. Monitor their level of consciousness. And of course, we want to also monitor for any GI bleeding that may occur. So looking for those dark cherry stools, the anemia, the nausea, vomiting, right? Because they're going to be at risk for bleeding because they're not making those clotting factors. And we have COPD. So what's COPD?
Say you
Anybody?
like the camera.
Say that again, Denasia.
I was telling Shay that we could hear her background.
Chronic
Um,
obstructive pulmonary disease. My daughter watching YouTube, sorry.
Chronic obstructive pulmonary disease.
Chronic obstructive pulmonary disease. And so what are some causes of COPD?
Smoking.
Smoking.
Smoking, absolutely. It could be physically smoking, or it could even be exposure to secondhand smoke. It could be chemical exposure. It could also be your things like emphysema is also one of your chronic obstructive pulmonary disorders. Um,
Genetics, right?
I'm sorry,
Genetics could be a thing.
genetics. Um, Chronic bronchitis is also one as well. So emphysema, they're the ones that will usually have that barrel chest. They'll have the shortness of breath, weight loss. Chronic bronchitis, they'll have the shortness of breath, the chronic cough, frequent respiratory infections as well. Um, so some of the interventions for COPD patients, stop smoking, right? Um, Reducing air pollution exposure could also be, think of some of the environments that some of our, clients will live in. They may have, lots of air pollution. Um, One of the big things with patients, especially with COPD in the later stages, is that chronic shortness of breath. Your COPD patients are often very thin, and it's usually the result of them being undernourished, because it's very difficult for them to eat, drink, breathe all at the same time. So, who's got kids? Okay. So, anybody had a child like when they were still on the bottle get like a stuffy nose and they get frustrated when
Policy.
they're trying to breathe and eat and when they're trying to drink their bottle?
Yeah.
Right? So think that's kind of like a COPD patient, okay? They're trying to eat, they're trying to drink, but they're short of breath, okay? And so it's hard for them to do all three at the same time. So we want to increase their protein, we want to increase their calorie consumption because they have a chronic disease or have an increased work of breathing. Their metabolic needs are higher, so they need to eat. So doing like small frequent meals, we don't want them overeating, right? Because think about it, think about tomorrow when you're eating that big Thanksgiving meal, what happens when you get full? Your belly fills up, it can increase the work of breathing as well because it puts pressure on the diaphragm and increases, this the shortness of breath. So even having them rest before meals, um, and one thing we also want them to do is to increase their fluid intake. That will help to thin out secretions. They also may be on oxygen therapy. Remember, with oxygen or with our COPD patients, right? We always do low flow oxygen, right? Because if we go too high, we can actually suppress the respiratory drive. Um, some patients may end up on corticosteroids like prednisone, right, to help decrease that inflammation. What are some concerns regarding corticosteroids? Anybody know? Like prednisone, what are some of
It
the adverse?
suppresses the immune system
It does. It affects their
and
immune
healing.
system. What does it do to our diabetics?
It hides if they're hyperglycemic.
Glycemic. Mm-hmm.
Yep, it increases their glucose levels. So, and then I don't know if anybody's ever taken prednisone,
Causes
but
weight gain.
weight gain, yep, it can cause some GI issues. It can cause some psychological issues as well. It's a great drug. It does wonderful things, but it does have some really bad, nasty side effects. Other things with our COPD patients is to make sure that they get their flu vaccines, their pneumonia vaccines, to try to help prevent some of those respiratory issues, right? And then we have diabetes. So we have two main types of diabetes, right? So we have our type 1 and then we have our type 2. What is the difference between type 1 and type 2?
Type 1 is an autoimmune. You're born with it. Type 1, you're born with it. Type 2, you develop it. That's from poor eating choices and other things.
Okay, so type 1 is autoimmune, where the
Your
pancreas,
pancreas doesn't make insulin.
very good.
And then type 2, like your cells stop absorbing insulin.
Good job. Yep. So type 1, we're not making any insulin. Type 2, we may be making insulin, but the cells are resistant to it, right? Or we may just not be producing enough. There's a genetic predisposition for both type 1 and type 2. Um, Most people are diagnosed with type 1 diabetes as a young child. However, it can develop at any time during a person's life. Um, so, what are the 3 symptoms of diabetes or hyperglycemia, I should say? What are the 3 main symptoms?
Frequent urination and thirst.
So, polyuria, polyphagia,
Arthus
and
and
polydipsia.
polydyspia.
There you go. So your 3 Ps. They're also, because of their high glucose levels, they're at risk for recurrent infections, poor wound healing. Um, Initially, before diagnosis, they'll also have weight loss. So even though they're hungry and eating all the time, they're thirsty all the time, they're going to have weight loss. Your type 2 diabetics, some of the risk factors for your type 2 diabetics is obesity, right? As well as advancing age. Um, and so as we get older, getting our hemoglobin A1C checked, um, as those levels start to rise, we can reverse type 2 diabetes with diet and exercise. All right. So if they're pre-diabetic or even early diabetic, if we get them on a good exercise, diet control, weight loss, stress reduction, it could potentially reverse it and they never need to have medication. And that, it's always good, right? That diet, exercise, weight loss, stress reduction, that's good for all diabetics. Um, One of the big things that we do worry about with our diabetics is maintaining really tight glycemic control. So we want really good, tight control of those glucose levels. Um, if we have really good control over those glucose levels, it will help to prevent some of those long-term complications like infections and ulcers, the neuropathies, the nephropathies, the retinopathies, even some of the cardiovascular complications, right? So we want to keep really good, tight control. That hemoglobin A1C, if you remember, the hemoglobin A1C is that blood test that we can do. It's going to give us an average of their glucose levels over the last 2 to 3 months. And it's a percentage. We want to try to keep that percentage less than 6.5. If we can keep it less than 6.5, that is associated with less of those or fewer of those complications. Um, what are so our type 1 diabetics will always be on insulin, right? They have to have insulin replacement, so they will be on insulin injections forever until the end from diagnosis. Our type 2 diabetics, right? We use our oral hypoglycemics, things like metformin. I'm trying to think of your glipizide, are some of the one metformin's probably the most common one that you're going to see with either one, whether you're using insulin or any of those oral hypoglycemic agents. One of the biggest risks that we worry about is hypoglycemia. All right. So, what do we do for somebody that has low blood sugar? What if
They
you go
might need
in?
something to eat to bring their blood sugar up.
Right, we need to give them to something to bring their blood sugar up. So, what are some good sources of glucose to give them to get those glucose levels up?
Orange juice, candy.
Orange juice. Orange juice.
I was gonna,
Say it again. I can hear
oh,
you.
it's okay.
Regular soda, so Pepsi, Coke, orange juice. Um, so when my mom was a diabetic, and so they have you can get the glucose gel. Sometimes the glucose gel is a little bit more expensive, but you can get those little tubes of cake icing for like $1. It's just pure sugar. Keep those in their pocket. There's glucose tabs and stuff as well. But you want to give them something quick, right? Something quick, something with just sugar to get their glucose levels up. But we also don't want them to then crash again, right? Because that you're just going to go up and down, up and down, up and down, and it's not good. So you want to give them something quick like orange juice or whatever, candy, whatever, sugar source. And then we want to give them something that's going to help to maintain. Um, so everybody let you know those little peanut butter crackers. I don't know why. Everybody loves little peanut butter crackers. Those are great. You give them the initial, glucose jump, and then you give them something like peanut butter crackers, or you give them a cheese sandwich, or something that has a complex carb and a little bit of protein that will help to maintain their glucose levels. Um, Trying to think of what else. Then we have PAD, which is peripheral artery disease. The primary cause of your peripheral artery disease is your atherosclerosis. Atherosclerosis, that's the thickening of the arteries, usually with a buildup of plaque in those arteries, leading to decreased blood flow to the extremities. Um, Trying to think of what else. Um, and it in the legs, it can cause what's called intermittent claudication, which is pain in the legs, like when they start to exercise, but then it's relieved when they rest. And it's just a result of blood flow that is not getting to where the muscles are getting to where it needs to go. Um, People with PNE are also prone to ulcers, um, which they're because they don't have really good blood flow. And we know blood flow is needed for ulcer healing, wound healing, I should say. The ulcers are very slow to heal, especially if you add, the fact that maybe some of these patients may have diabetes on top of that. Um, I'm trying to think of what else. So the best thing for them to do is exercise, walking. Walking will help to improve circulation. Um, no smoking. One thing with your PAD, which may be a little bit different than what we're used to, is we don't want to use compression. All right. So you don't want to use those compression socks. So we want to avoid compression of the extremities, keeping the, feet elevated when they're laying down. Um, may also be helpful. Then we have our wonderful hypertension. So hypertension is known as the silent killer. Why is hypertension known as the silent killer?
Because
Have you heard
sometimes it
that
doesn't have
before?
symptoms.
Right. So a lot of people don't have symptoms of hypertension until there's already damage to end organs that are done. Um, and so it's anything over 130 over 80 or higher. Diastolic blood pressure is usually the focus of the treatment. All right, so that bottom number is really what we're looking for. Um, so how do you get diagnosed with hypertension? Do you go to the doctor and they take one blood pressure and they're like, oh, you've got hypertension? How do we get diagnosed with hypertension?
No, having a constant reading of high blood pressure.
Okay. So they need to have their blood pressure is taken on, right? Couple of different occasions. at least a week apart for them to be diagnosed with having high blood pressure, right? Because has anybody ever heard of white coat hypertension? Right? Some people,
You get scared of
and
going to the doctors.
mhm,
The blood pressure gets high.
yep, they get nervous when they get around the doctors and their blood pressure goes up. And even kids, when I worked in peds, we had kids that had white coat hypertension. So it's something very, it's very real. Um, so, okay, you get diagnosed with hypertension, okay? What is the initial, what are we gonna, what are some of the first things that we want to do for our hypertensive patients as far as treatment goes?
Bring their pressure down.
We want to bring their pressure down, absolutely. How can we do that?
Sometimes they'll get on medication, but also a low sodium diet.
So much like that, pre-diabetic, all right, we're going to do the same thing. Diet, exercise, weight loss, quit smoking, stress reduction. A lot of times for some patients that may be all they need to do to keep their blood pressure under control. Um, and then of course, if that is ineffective, right, then we are going to start with medications. And so, um, usually they'll start with like a diuretic, and then we can add medications from there. When we look at blood pressure too, in addition to just the traditional, what are some of the risk factors for developing hypertension?
Being
Obesity.
Why is it always got to be age? Yes. It's always age, right? The risk is always going to be increased with age. What ethnicities are at the highest risk?
African American and Hispanic, I think.
Yeah, African Americans, Hispanics, Native Americans, your Hawaiians, your Asians as well, are at risk. If they have a family history of hypertension, if they smoke, if they drink, if they're obese, if they have diabetes, high stress, right? So like all nurses should have hypertension then, right? Um, all nursing students should have hypertension. Um, High sodium consumption, sedentary lifestyle, decreased kidney function, all of those things could potentially lead to a diagnosis of hypertension. Um, so think of those. So we talked about, diet and exercise. So someone said decrease the sodium. Yep, absolutely. Right. Decrease the sodium in the diet. One of the big things that we need to do with decreasing sodium in the diet, is teaching them how to read those food labels. Anybody read food labels? It's scary, isn't it? And look at some of the foods and the amount of sodium that are in some of those foods. Um, Exercise. May need to also make some other dietary changes for weight loss, getting them to quit smoking. That includes vaping, um, reducing caffeine intake. That would be my downfall right there, is reducing my caffeine intake. But caffeine is a stimulant as well. It's going to increase blood pressure. Um, so it's a lot of education. It's a lot of follow up. It's a lot of follow through. Um, because like I said, it's a silent killer, and a lot of people don't even know that they have hypertension until there's already damage done. And so we really need to make sure that we are identifying them and we are educating them on how to reduce their risk factors, right? Because We can reduce the modifiable risk factors, right? We can't do anything about their age or their ethnicity or their family history, right? But we can do things about the obesity and the um what else? The diet, the smoking, right? We can even manage, their high cholesterol levels. We can get them up and moving, right? And that will all help. Um, they may still need to be on medication, but if we can, get that blood pressure back down into within a normal range, we can potentially, ward off some of those complications. What are some of the potential complications of hypertension if we don't get it under control?
Heart attack,
Heart
stroke.
attack, stroke, kidney damage, right? So there's a lot of potential complications that can occur. All right, and then the last is our chronic venous insufficiency. So we talked about peripheral artery disease. Chronic venous insufficiency is usually the result of incompetent valves in the veins, right? So when you think about the difference between veins and arteries, veins have valves, and valves help to prevent the backflow of blood. And so if those valves are incompetent, then we're going to have the backflow of blood. And so if those valves don't close normally, then the venous blood is not going, it's not all going to go back to the heart like it is supposed to, which leads to swelling in those lower extremities. And with the swelling, we have pressure buildup, and it also can cause um, the fluid to leak out of the vessels into the skin. And a lot of times they'll lose red blood cells as well. And that is what causes, I don't know if anybody has ever seen anybody with chronic venous insufficiency, but they're the ones that have that like brown leathery skin, especially around their like lower calves and ankles. It's like really brown and leathery. Like you may see it just like even just walking out in public. Um, but there's the skin also, especially around the ankles, gets like really thick. It gets hardened. Sometimes it can be itchy and scaly as well. They also can develop ulcers with the chronic venous insufficiency. Um, the difference between peripheral artery disease and venous insufficiency, with the venous insufficiency, we want those compression stockings. Okay, we want the compression bandages because one of those compression things, what do the compression stockings do, right? They help to encourage blood flow back to the heart. All right. So that's what we want to do, right? We're trying to help the blood get back to the heart to get pumped. Um, and then hypertension, diabetes also are potential causes of chronic venous insufficiency. So we want to keep that under control as well. All right, 2 minutes to spare. What questions do you have for me?
Are we gonna have exam review like last time?
Yes. So on the calendar, because I forgot the date. So I want to say it's the 7th, but let me not. Yeah. So on December 7th, 208 is at 7 p.m. for your exam review, Eastern Standard Time. And then on the 14th at 7 is going to be your HESI live review. So you still have exam 3 review, and then there'll be a HESI review on the following Sunday.
I
So
have a
again,
question.
sure.
Go ahead. I have a question about our vulnerable populations project.
Yes,
Does it
ma'am.
have to does it have to be one of the topics that you provided, or can we pick?
As long as it's a vulnerable population, I just listed some of the more
Okay, and is it supposed to be any certain format or anything like that, or a certain
PowerPoint.
amount of slide? Yeah, just a PowerPoint.
It's a PowerPoint, so you have to have a title slide and a reference slide, and then however many slides you need in between.
Okay.
Mhm.
Is there like a minimum you'd want?
Mm-mm. Nope. All
And
right.
references, is there a certain amount of references that we need to have? Because I know last time we had to have 5. Okay.
Nope.
All right.
All right, everybody. I hope everybody has a wonderful Thanksgiving. I hope everybody has some time this weekend to get some rest, relax a little bit, and then come back. We'll have 3 weeks left. So keep up the good work, all right? And enjoy your little mini vacation, mini holiday. And I will see everybody next week.
All right, bye. Happy Thanksgiving.
Thank you.